Welcome to our video on uterine atony, placenta accreta, retained products of conception, and coagulopathy. Let's get started. Let's start by revisiting a slide that highlights the causes of postpartum hemorrhage, which some students remember as the 4 T's. This mnemonic groups the causes into one of 4 categories: trauma, tone, tissue, and thrombin. In the previous video, we reviewed the traumatic causes. In this video, we'll focus on the remaining causes, so tone, tissue, and thrombin. With that in mind, here is the overview slide for the causes of postpartum hemorrhage that we'll be focusing on in this lecture. Let's start with uterine atony. This is the part of our second T, which is for tone. By definition, uterine atony is the loss of uterine tone. Put another way, this is the inadequate contraction of the muscle layer of the uterus after delivery. Here we see a depiction of the blood supply to the uterus. The pink layer is meant to illustrate the myometrium, and the deeper yellow layer is the endometrium. We'll focus our attention on the spiral arteries in particular. These arteries are unique in that they don't have a muscle layer. This means that when they're bleeding, such as occurs after the placenta separates from the uterine wall, they can't contract down to achieve hemostasis. Instead, they rely on compression from the contracted myometrium to stop their bleeding. In patients with uterine atony, the muscle layer of the uterus is relaxed, and this mechanism is impaired, leading to bleeding. Put in words, the vessels throughout the placental bed rely on compression from the contracted uterus to stop bleeding. If there is inadequate constriction of these vessels, the patient bleeds. Risk factors for uterine atony include anything that makes it more difficult for the uterine muscle to clamp down on the underlying vessels. This can occur when the uterine muscle is tired because of a prolonged induced or precipitous delivery. It can also happen in the case of an enlarged uterus, such as would be the case in a patient with multiple gestations, macrosomia, or polyhydramnios. It requires more energy to contract a large and stretched uterus than a small one. The presence of an intra-amniotic infection or usage of magnesium sulfate can also predispose a patient to uterine atony. All right, let's try a question. Why does the administration of magnesium sulfate during pregnancy increase the risk of uterine atony? Magnesium sulfate is commonly used during pregnancy, particularly as a way of preventing seizures in patients with preeclampsia. In addition to its anti-seizure effects, this drug has tocolytic properties, meaning that it decreases the contractility of the uterus. Because of the secondary effect of uterine relaxation, uterine atony and subsequent postpartum hemorrhage can result. Note that in practice, this drug is rarely used for this purpose because it's not effective in decreasing preterm delivery, and its prolonged use may lead to defective fetal bone mineralization. All right, let's return to our algorithm for evaluating a patient with postpartum hemorrhage. Recall that the first step in a patient who is bleeding after her delivery is to evaluate the position of the uterus. If the uterine position is abnormal, we need to assess whether or not the uterus is even inside the abdomen at all. If it is felt within the abdomen, but it is palpable above the umbilicus, this is abnormal. We should perform a bimanual pelvic exam, which is likely to reveal an enlarged and boggy uterus. If this is the case, we have our diagnosis of uterine atony. No further imaging or diagnostic steps are necessary. One thing to be wary of with this diagnosis is that a large amount of blood can pool in the lower uterine segments before it becomes frankly visible from the vagina. For this reason, assessment of the uterine position and tone following delivery is critical. Let's illustrate what this looks like. On the left, we see a normal uterus that has adequate tone. On the right, we see a uterus affected by uterine atony. Notice the way that the uterus is enlarged and appears to be floppy and without tone. Management of uterine atony begins with a bimanual uterine massage to try and firm up the uterus. High-dose oxytocin is administered next. Oxytocin is usually given in some amount to all patients following delivery to prevent this complication, but we need to increase the amount if uterine atony develops. If these measures aren't enough, we can give tranexamic acid. This medication is an antifibrinolytic designed to help the body better maintain its ability to clot. If the bleeding continues with this, we can employ a secondary uterotonic agent, such as methyl-ergonovine, carboprost tromethamine, or misoprostol. Misoprostol might be a touch less effective than the other two, but ultimately the choice of which of them to use is guided by the physician preference and patient contraindications. If medical management fails, we turn to other more invasive treatments. The specifics of these last 3 interventions will be discussed at the end of this lecture because they apply to all cases of continued postpartum hemorrhage. All right, let's try another question. What is the contraindication for using methyl-ergonovine in the treatment of postpartum hemorrhage? Methyl-ergonovine is a drug that is used to contract down the uterus in instances of postpartum hemorrhage, particularly when uterine atony is the cause. In addition to being a uterotonic medication, this drug acts as a vasoconstrictor. Because of this, it's contraindicated in patients with hypertension as it increases the risk of stroke. To help remember this high-yield association, notice that the letters H and Y at the beginning of the word hypertension are also present in the word methylorgonavine. Okay, here's another question. What is the contraindication for using carboprost tromethamine in the treatment of postpartum hemorrhage? Like methylorgonavine, carboprost tromethamine is a drug used to clamp down the uterus and decrease bleeding. It works as a prostaglandin F2 alpha analog. Given this mechanism of action, it can also result in bronchospasm and is therefore contraindicated in patients with asthma. At the hospital, this medication is often called by its brand name, which is Hemabate. To help remember that we don't give Hemabate to asthmatic patients, consider the memory hook Huff Huff Hemabate. Huff Huff is the sound that an asthmatic patient might make, and we do not want to give them Hemabate. Alright, our next topic is Placenta Accreta spectrum. Together with retained products of conception, this is our third T, which stands for tissue. Both of these diagnoses involve tissue abnormalities causing bleeding. Placenta accreta spectrum used to be termed morbidity-adherent placenta. Put simply, this is an abnormal placenta that is invaded too deeply. The placental villi are attached to the myometrium instead of the decidua of the uterus. Let's look at this closer. On the left, we have a normally attached placenta connected to the decidua, which is a mucosal layer of the inner uterus. On the right, we see the 3 different abnormal placenta types that make up the placenta accreta spectrum. Each of these occur as the trophoblast improperly invades and leaves the placenta too deep. Placenta accreta occurs when the placental villi are attached to the myometrium, which is the muscle layer of the uterus that sits deep to the decidua. Placenta increta is when the villi invade a touch deeper, penetrating the myometrium. Finally, placenta precreta is when the villi completely transverse the myometrium and begin to attach to the uterine serosa or other nearby organs. The number one risk factor for this condition is placenta previa following a prior delivery by C-section. Any area of scarring within the uterus, which can be caused, for example, by a D&C, myomectomy, or C-section, can create an environment wherein the placenta may implant abnormally. In a patient with prenatal care, a second trimester ultrasound can be used to diagnose placenta accreta spectrum. In this algorithm, we'll walk through how this diagnosis is made in a patient without prenatal care, which may be the most dangerous of scenarios because it's unexpected. This patient will have PPH with a normal uterine position and no sudden loss of fetal station during delivery, and they'll also have no history of easy bleeding. A big clue is that the placenta may be delivered in fragments, or we may struggle to deliver it at all. In addition, there won't be normal signs of placental detachment, such as lengthening of the umbilical cord and a gush of blood from the vagina. Were we to do an ultrasound, though this isn't necessary, we would note an endometrial mass. This aspect of the algorithm can also remind you that ultrasound is a great way to diagnose this in someone with prenatal care. Management of these patients is emergent laparotomy and hysterectomy in patients diagnosed at the bedside because of inadequate prenatal care. In patients diagnosed before labor, a planned cesarean hysterectomy is performed. Alright, let's try another question. Should the placenta be delivered before performing a hysterectomy in a patient with placenta accreta? The correct answer to this question is no. In these patients, the placenta is so tightly attached to the uterine wall that attempts to remove it are likely to cause additional bleeding. Instead, we perform a hysterectomy with the placenta in situ, meaning left inside the uterus. Okay, now let's move on to discuss retained products of conception. Retained products of conception refers to tissue from the baby or the placenta that stays inside of the uterus after pregnancy. This retained tissue can lead to significant bleeding, presumably because it impairs the uterus from adequately contracting. Risk factors for this include a succenturiate placenta, which is an abnormally shaped placenta that will be shown on the next slide, as well as manual extraction of the placenta, prior uterine surgery, and intraamniotic infection. With an intraamniotic infection, the inflammation results in the placental membranes grabbing onto the uterine wall and not detaching properly. Here we see an illustration of a succenturiate placenta. This is a placenta with an accessory lobe that has its blood supply feeding from the main placenta. This additional placental tissue can stay behind during the removal of the primary placenta and cause bleeding. Alright, so working through the algorithm, we move again down the side of normal uterine position, no sudden loss of fetal station during delivery, no history of easy bleeding, and the fetus or placenta being incompletely delivered. In contrast to placenta accreta spectrum patients though, there do tend to be signs of placental detachment. If all of this is true, we should perform an ultrasound to evaluate for a partially retained placenta or retained products of conception. This will show an intrauterine mass. Here is a pelvic ultrasound showing a normal non-pregnant uterus. The anechoic area in the center is where the normal saline has been injected for better visualization. Where there are retained products of conception, they would appear as a gray, echogenic area within the uterus. Once we see this finding on ultrasound, it's worth considering the timing. If it has been there for more than 24 hours, the patient likely has retained products of conception, since this is the most common cause of delayed or secondary PPH. If it's been fewer than 24 hours, you should be thinking about a partially retained placenta. Management of a partially retained placenta is usually with manual extraction, sometimes under general anesthesia. Retained products of conception, which tend to be fetal tissue that remains following a miscarriage, are commonly treated with D&C. All right, here's another question. 2 days after a vaginal delivery that required manual extraction of the placenta, a woman presents to the clinic for moderate lower abdominal tenderness. Her temperature is 38.1 degrees Celsius. What is the most likely diagnosis? All right, the correct answer to this question is postpartum endometritis. This is an infection of the endometrium that is more common in patients requiring manual removal of the placenta. 2 of 3 criteria need to be met to make this diagnosis. The criteria are fever, lower abdominal or uterine tenderness without another known cause, and purulent uterine drainage. Our patient meets 2 of these because she has a fever and lower abdominal tenderness. The treatment is with broad-spectrum antibiotics. So again, the answer to the question is postpartum endometritis. We'll conclude this lecture with a brief discussion of coagulopathy as well as last resort management. So coagulopathy falls under the umbrella of the final T in our mnemonic, which stands for thrombin. Recall that thrombin is an important component of clot formation as it converts fibrinogen to fibrin. For the final aspect of the algorithm, we have a patient with a normal uterine position and no loss of fetal station during delivery. However, they do have a history of easy bleeding or bruising and recurring or prolonged postpartum hemorrhage. They may describe bleeding while brushing their teeth or have very heavy periods. If this is the case, we need to order a coagulation profile. This looks at the patient's INR, APTT, fibrinogen, and platelets to help screen for different bleeding disorders. Once we make a final diagnosis, we'll treat the underlying disease accordingly. All right, here's another question. How will the bleeding time and platelet count be affected in a patient with von Willebrand disease? To answer this question, we need to think about the function of von Willebrand factor, which happens to be deficient in patients with von Willebrand disease. It has various roles, including helping platelets adhere to the endothelial membrane, promoting platelet aggregation, and carrying factor VIII protein. Without it, platelets don't work properly, and the bleeding time is subsequently increased. Because this disease does nothing to affect the production or viability of platelets, the platelet count remains the same. Okay, with this in mind, let's move on to discuss the last resort management of postpartum hemorrhage. So this applies to all of the diagnoses that have been described so far. We generally don't turn to these techniques until medical management has failed. First is the intrauterine balloon tamponade, which is exactly what it sounds like. It's a balloon that's inflated within the uterus to try and compress the injured vessels and stop the bleeding. The O'Leary suture is a specific technique used to clamp off the uterine arteries bilaterally. The B. Lynch suture is where the suture is thrown around the entire uterus. Hypogastric artery ligation is another option, but it's rarely performed and requires significant skill. Finally, hysterectomy or removal of the uterus can be undergone in severe cases where nothing else is working. Here we see an image depicting the O'Leary suture, which is used to ligate the uterine arteries in cases of severe PPH. A suture is passed through the uterus and around the uterine artery before being tied down. This is usually done bilaterally, as shown here. 2 sutures are often thrown at the top as well to decrease overall blood flow to the uterus. Here we see a depiction of the B. Lynch suture technique. The dotted lines show the suture wrapping behind the uterus in the back, and then the dark lines show it coming around in the front. Clinching this tight provides external compression of the uterus to slow the bleeding. All right, let's wrap up with one final question. A 28-year-old Gravida 1 Para 2 is assessed at the bedside for moderate vaginal bleeding that has continued for 20 minutes post-delivery. She experienced the vaginal delivery of twins, weighing 3 kilograms and 2.7 kilograms after being in labor for 18 hours. She has a 5-year history of hypertension that has been well controlled throughout her pregnancy with nifedipine. She currently feels lightheaded and weak. Temperature is 36.7 degrees Celsius, respiratory rate is 15 breaths per minute, heart rate is 92 beats per minute, and blood pressure is 104/71 millimeters of mercury. The uterine fundus is palpable above the umbilicus. The vaginal exam reveals no evidence of lacerations. Bimanual uterine massage is being performed. What is the best next step in the management of this patient's bleeding? A. Tranexamic acid. B. carboprost-tromethamine, C. high-dose oxytocin, or D. intrauterine balloon tamponade. Alright, a vignette such as this is almost certain to appear on your OBGYN shelf exam. There are a few clues as to the best diagnosis for this patient, which needs to be made before we can determine the best next step in management. Notice that she's experiencing postpartum hemorrhage and the uterine fundus is palpable above the umbilicus. This sounds like uterine atony. The fact that there is no evidence of vaginal lacerations helps to confirm this. Once we have the diagnosis, we just need to follow our algorithm to determine the best next step in management. So the first step for a patient with uterine atony is to perform a bimanual uterine massage, which is already being done. Next, we should give oxytocin. This tends to be started automatically at the hospital, but wasn't mentioned in the question stem, so this is the correct answer. After this, we would consider adding tranexamic acid before implementing secondary uterotonic agents. So returning to the question stem, answer choice C, high-dose oxytocin, is the correct answer. Choice A is incorrect because tranexamic acid isn't given until after oxytocin has been started. Choice B is incorrect because carboprost-tromethamine is more of a second-line agent for treating postpartum hemorrhage after other interventions have been undergone. Were we to need a secondary uterotonic agent though, this would be a great option, since methylorgonavine is contraindicated in this patient given her history of hypertension. Choice D is incorrect because usage of an intrauterine balloon tamponade is more of a last resort treatment option after traditional medical management has failed. So again, the correct answer is choice C, high-dose oxytocin. And that concludes this section.